Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, I'm Susan Kaufman and you're listening to Attitude Magazine's ADHD Experts Audio. Our topic today is children, and our expert guest, I'm extremely pleased to say, is Dr. Thomas Brown of Yale University. Dr. Brown will be talking about diagnosing children, how the symptoms differ from child to child, how do you distinguish between a variety of symptoms that may suggest other conditions such as anxiety, depression, learning disabilities. And then he'll also address the topic that many of you have asked about. What are the best practices in treatment? When do you decide to go ahead with medication? Many of you would prefer not to do that, as I think many parents agree. And he'll address some of your questions about alternative therapies from fish oil to cognitive behavior and so forth. Dr. Brown is an assistant clinical professor of psychiatry at Yale University School of Medicine. He's the associate director of the Yale Clinic for Attention and Related Disorders and the author of a number of truly helpful books. I can't stress enough how clear and helpful his books are, both about what ADHD is and case studies about people who live with it and how, especially young adults, and how they've been treated. And with that, let me turn it over to Dr. Brown. Thank you, Dr. Brown.
Thanks, Susan. I'm very happy to be back. The first thing that I'd like to talk about is the fact that there are a lot of differences among people with ADHD. You know, there are the obvious differences of age and gender, and it's true that ADHD certainly looks a lot different in a preschooler than it does in a fourth grader and than it does in an adolescent and an adult. And there are some significant differences usually between the way girls and boys present in earlier years, although for those who are interested, I can tell you that among the clinics that treat ADHD in adults, it's quite different. Generally, with children, the ratio of boys to girls is, who are brought in for treatment is about 3-for-1, about 3 boys for every 1 girl. And for a long time, people thought this was just a boys' problem. But what we now know is that if you take a look at the number of women who come in for assessment and treatment in adult clinics, that number is much closer to 1-to-1. And when you look at that, you can sort of scratch your head and say, well, what's up with this? And it seems like the first thing, the obvious thing, is that most girls don't make so much trouble with their parents and their teachers that they're likely to get brought in for treatment when they're young, particularly if they're pretty bright and are not making any trouble. But what happens often is that many girls and teenage girls and younger girls and women suffer from problems of ADHD that don't include so much making trouble for anybody else, but they suffer with trouble for themselves in terms of being able to focus and utilize short-term memory and so forth. And what happens is they don't get brought in for treatment until they're old enough to bring in themselves. And so when we look at that, many of us are saying, well, you know, the ratio between boys and girls, men and women, is probably not as wide as 3 boys, males to every 1 female. That may be more a bias of the way in which cases are reported. There are a lot of girls and women out there who have these difficulties who do not get reported to come in or seek treatment until they're old enough to be able to see it as a problem for themselves and they're old enough to make it happen. The next thing I was going to mention was the age of having the symptoms noticed. You know, for decades, this was seen as a problem of just little kids, preferably little boys, or generally little boys. And in fact, the old diagnostic manual back in 1980 said that the usual age for presentation of first symptoms was 3 years old, and that generally it would be seen for the first time before a person got into first grade. But the fact is that that was a very old notion of what ADHD is, and it was at a time when the focus was very much upon hyperactivity and impulsivity. At that time, the disorder was thought of as essentially a problem of little boys who couldn't sit still, wouldn't shut up, and were driving everybody nuts. And from 1902, which is one of the first reports of this in the medical literature, in the English medical literature, until 1980, this was thought of, names changed a few times, but this was thought of essentially as a problem with hyperactive behavior, misbehaving kids for the most part. And it was not until 1980 that the new diagnostic manual that was brought out in that year introduced the words attention deficit into the name of the disorder. And what we now know is there are many people who have ADHD or ADD, I tend to use those two terms interchangeably, who've never had any significant behavior problems. And even for those who have, that's usually the least of it, is the attention problems that tend to make more trouble for people. And from that follows the fact that there are some people with ADHD, for example, who do very well and are even honor students in elementary school. And then often things get a little bit shaky in middle school and a little shakier in high school. And it's usually that point where the child moves from having one teacher most of the day who can provide considerable structure and support and scaffolding for the whole class into middle school, where now suddenly you've got to deal not with just one teacher most of the day, but with 3 or 4 or 5, and then into high school where much more independent work is required, and you've got a whole different set of teachers for your classes, so that you're moving from one to another, and you have to remember what's the homework for this class and the homework for that class, when is that quiz going to be, what's the test going to be, what materials do you need to take out of your locker or out of your book bag and have them ready for that next class. And it's much harder to keep track of things. It requires a much improved level of organization and focus, and that's the time you begin to see it with some kids. My specialty is high IQ folks with ADHD, and many of the people I see who are very, very bright they were like honor students up until they got into about 6th or 7th grade, and then things began to get a little shaky. However, there are some whose parents do such a good job of providing that son or daughter with scaffolding, helping to organize them and plan for them and remind them about what needs to be done and encouraging and pushing them to get the right thing done, that nobody sees the problem until they actually move away from home, for example, to go off to college. And I see a number of kids who have done very well in high school, very high grades, and very well behaved, very functional in activities, who get to college where all of a sudden that scaffolding that's been provided by their parents is removed, and they crash and burn. And it's a difficult decision for many parents as to how much support to provide and how much to let their son or daughter just sort of make it on their own and get the consequences. Because the fact is, some of these kids really do need more help and support from their parents than many others would at that age. And yet at the same time, mom and dad do not want to have to move into the college dormitory in the room next door to their son or daughter. And so it's a matter of trying to scale the level of support and scaffolding you provide for your son or daughter to help them get the capacity to function more independently. So sometimes we can see this very early on. There are some young kids that at age 3, 4, 5, you really can see a lot of difficulty and say this child is much more difficult to manage and has very much less control than most kids of the same age. Can't cross the street safely, even just walking beside me. I have to hold his wrist much longer than you'd hold the wrist of a kid of comparable age. But there are many others where it's not noticeable until much later, and there's some where they seem to get along all right, even through college. But then when they have to go out and get a job and try and keep a job, things get more complicated. It depends on what the demands are that are placed on a person at each transition point in their life. You know, the picture that we have of ADD is one that is, I think, confusing to a lot of people. And what I refer to sometimes in what I've written is the mystery of ADHD. And that mystery is quite simple, really. And that is that everybody I've ever seen, and that's quite a few people who have ADHD, every one of them has a few things where they can pay attention very well, and they have no trouble in being able to organize, get started, sustain effort, sustain attention, for that particular activity. Keep things in mind, one thing in mind while doing something else. All those executive functions that we talk about as characteristic of ADHD the impairments of those just disappear when they're doing that activity. Now, it might be a sport that they play, baseball or football or lacrosse or hockey or basketball, whatever. Or it may be playing video games that they're able to focus intently when they're doing video games. Or it may be that they really enjoy doing artwork and drawing. For others, it might be taking a car engine apart and putting it back together when they're older, and doing fantastic constructions with Lego blocks when they're younger. But everybody I've ever seen, it's different things for different people, but everybody I've ever seen who has ADD has a few things that they like to do where they can pay attention and exercise these executive functions very well. The problem is they have great difficulty doing it for everything else. And so people look at that and they say, well, what's with you? If you can pay attention so well with this sport you're playing, or with this the things you're making in woodshop, or with building these Lego constructions, why is it you can't pay attention when you're in class? Why is it that you can't get on top of your homework and work at that more intently? And it looks as though the person just has a problem with willpower. If you can do it here, why can't you do it there? And there are many times teachers and parents look at that, and often the person himself or herself has the same feeling, well, why can't I do it here? And the other place where sometimes you see the same mystery appearing in just a slightly different form is where they wait till the last minute for something and then suddenly can deliver it, can write the paper they've been struggling to write and avoiding for a long time, or get this other project done. And usually what you find is that if you ask people who have ADD the question, well, why is it you can do it here and not there, or now but not before, when it would have been more sensible to do it, they'll usually say, it's easy. If it's something I'm interested in, I can pay attention. If not, I can't. And most people hear that and they say, well, congratulations, that's true for anybody. Anybody's going to pay attention better for something that they're interested in than for something they're not. But they dismiss it. But the fact is, if you look at the situation, what you find is for most people, if they've got something they've got to do and they know they've got to do it, even if it's pretty boring, they can just usually make themselves pay attention, even if it is pretty boring. People with ADD, it's really hard for them to be able to make themselves pay attention for something unless the task is something that's really interesting to them, or they feel they have a gun to their head and something very unpleasant is going to be happening very fast if they don't take care of this right here, right now. Under those two conditions, no problem. Under the other conditions, often a lot of difficulty. And so that's how it looks like it's a problem with willpower, when in fact, it's a problem with the dynamics of the chemistry of the brain. It looks like a problem with willpower, but it's not. And that really is confusing to teachers and to parents and to people themselves who have it, about why can't I do it here when I want to do it, and I know I should, when I can do it so well at other times. So these are the things that are puzzling to people, and that I would say it's fair to say that ADHD looks like a problem with willpower, but it's just not. And that takes a lot of explaining for people to really understand it. Now, when you read about the list of symptoms of ADD, often people look at that and say, well, those are all things everybody has trouble with sometimes. That's absolutely true. Now, if you read that list of symptoms, all of us have difficulty from time to time with each of those symptoms. The difference between people who have ADD and people who don't have ADD is not an all or nothing difference, like the difference between being pregnant or not pregnant. Either you're pregnant or you're not pregnant, and there's no in between. It's not like that. The difference is more like the difference about depression. Everybody feels sad or unhappy once in a while, but just because somebody's unhappy for a couple of days doesn't mean we're going to diagnose them as clinically depressed. It's only when those depressive symptoms are persistent and making a lot of trouble for them we say, yeah, that's a depression, we should do something about it. So all of this is stuff everybody has some trouble with. All these symptoms are things that are common to everybody. The question is how much trouble, how severe, how chronic, how persistent is the impairment. And those are the people, the ones who seem to have this difficulty in a lot of different situations, even though it's not present in every single situation that warrant having evaluation. So when you're going to get an evaluation, what do you want to do? Well, first you need to find somebody. It might be a pediatrician, it might be a psychiatrist, it might be a psychologist, It might be some other mental health specialist, but somebody who knows and understands ADHD and what it looks like and how it's similar to and different from other problems. So you want to get the right kind of person to do it. And you might want to ask your local CHAD group who they've had good luck with. You might want to ask your physician because the fact is that very few people who work in mental health or medical professions learn anything about ADHD, particularly in adolescents and adults, when they're in school. Maybe 20 minutes in all of a medical school education devoted to that particular subject. And so you want to find somebody who has an interest in it and who's got some training in it. And what's the most valuable instrument we have for assessing ADHD? A well-conducted clinical interview where the clinician inquires and asks a lot of questions to learn from this child or this teenager or this adult and from people who know them well what things are easy for them and what things are hard for them. Is it that school was easier before and now it's getting progressively harder? Is there more demands for independent work? Is this something that's been going on for quite a long time, or has it just started? You want to sort out, is this a reaction simply? Is it a period when the person's depressed or when there's been some crisis in the family that's maybe interfering with their ability to focus and function? And that interview takes me usually 2 hours to do a full clinical interview for somebody to get an idea of whether or not this person meets diagnostic criteria. But it ought to include not just the questions and answers of a semi-structured interview, but also a rating scale that's normed and that's appropriate for this person that's going to be asking about ADHD, not just in terms of hyperactive impulsive behavior and not just in terms of can you listen when somebody's talking to you and pay attention, but for the wider range of what we call executive function, which the impairments there are associated with, difficulty keeping one thing in mind while you're doing something else, difficulty regulating emotions so they don't get too much in the way, difficulty getting organized and getting started on stuff, difficulties in staying focused and then shifting focus when you need to, difficulties in regulating sleep and alertness and being able to sustain effort and work at a reasonable rate of speed on tasks. It's that full range of things. And the rating scale ought to be one that's appropriate for the age of the person, and it asks about the full range of ADHD and executive function impairments. Then you want to check health history, because there are some problems. For example, somebody who's got a low thyroid problem, which may not be diagnosed, can be having a lot of ADD-type symptoms and a lot of fatigue, which is due primarily to the functioning of their thyroid. It's a hypothyroid condition. Is there any other health problems? Is there some medicine the person's taking that could be making difficulty for them? How are they doing on things like eating and sleeping? Their vegetative signs. So the clinical interview needs to include these things as well. And of course, you need to think about the question of, is this an adolescent or an adult who's doing a lot of drinking or who's getting high on marijuana frequently? Because certainly those things can cause some very similar problems if they're ongoing problems. And then in the process, there also needs to be a screening. If you have ADHD, you've got, as an adult, you have 6 times the likelihood of having at least one other psychiatric diagnosis at some point in your life. Now, that might be a learning disorder. It might be depression, a mood disorder. It might be a substance use problem. It could be OCD, anxiety, panic disorder. It doesn't mean everybody who has ADD has these things going on all the time, but it means that this is a population of people who, because of the difficulties associated with the executive functions that are characteristic of ADD, typically there will be some times when they have some of these other difficulties. And so one needs to check into that and see, how the person's doing. And often that'll be picked up in the routine of the clinical interview, but one element ought to be asking about other possible problems. And others and I have published listings of things that can be used with a diagnostic interview to inquire about that sort of thing. Now, once an evaluation has been made and a person's received a diagnosis of ADHD, then the next question, of course, is what to do about it. And the question there becomes one of what is the severity of the problem? Because I mentioned at the very beginning that people with ADHD are not all alike. Well, one of the ways in which they're not all alike is the severity of the problems. ADD, like many other things, comes in small, medium, and large. And there are some people who have some ADHD problems that are a little problematic for them, but they don't get in the way very much for them. There are others where it's more substantial and it is intruding on their ability to do their job or do their schoolwork and get along with other people. And then there are some people where it's very severely impairing. And so you want to look at the severity of the difficulty as you think about interventions. And then the question is, what can we do? Now, essentially, ADHD is tied primarily to problems with the chemistry, the dynamics of the chemistry of the brain. And the most effective treatment that we have at this point is medication, carefully tailored medication. It's not just a matter of pushing pills at people. It's a matter of being able to assess this particular person, their overall health, their levels of functioning, what they're having trouble with and what they're not having trouble with, and what other things might be going on as problems for them, and try and see if it's possible to get a dosing of medication that would be helpful for this person. And what we know is for the types of medicines that we use most often, because we've had them the longest and they usually work best for most patients, about 8 out of 10 people are going to find the medication helps them. Now, for some people, that medication benefits them. The benefits are huge. For others, they're substantial, but they're not huge. For others, they help a little, but not that much. And for about 20%, they don't do a damn thing. Now, we do have some non-stimulant, a couple of non-stimulant medicines that sometimes are helpful for those people who don't respond well to stimulants or can't take them. But the fact is the success rate for these medications are about as good and better than the results you get for medication for most other medical disorders. And if it's carefully tailored, the dosing and timing of doses is carefully tailored, that can make a big difference, because these medicines, the amount you need has nothing to do with how old you are, how much you weigh, or how severe the symptoms are. It's how sensitive is your body to it. You know, I see little kids, I see teenagers, I see adults. Most of the little kids are taking very small doses, but there are a few of them, just as small as all the rest of them. We've got to go to the top of the adult dosing range to touch them because their bodies aren't that sensitive to it. And on the other hand, among the adults I see, most of them are taking fairly hefty doses, but there are some of them way taller and heavier than most other adults in the group who are taking no more than you give a typical 6-year-old. So you need to take into account that the amount that you're looking for that's going to be optimal for that person is that special place between too little and too much. If you have too little, you might just as well be taking breath mints. It's not going to do a damn thing. That means too little for that person. If you have too much for that person, they're likely to be getting jittery or crabby or too focused and sort of lose their sparkle and their spontaneity. So the timing and also you have to figure out, for example, a lot of the extended release preparations of medicines don't work much more than a school day and maybe an hour or two beyond it. And that doesn't hold, for homework that kids have to do, or for adults, it doesn't necessarily get them through a work day. And so you have to augment these so-called all-day preparations that usually mean all school day, if you're lucky, with short-acting medications to cover late afternoon and early evening. So that's all part of the getting things tailored to each person. The other thing that I'd like to say before I go on to taking questions is that medication is the most effective treatment we've got, although, as I said, it doesn't work equally well for everybody, and it doesn't work at all for some people. But even for those where the medication does work, often people with ADD need more than just pills to help them. For some, they need some behavioral plans, particularly young kids where you're trying to get them to modify their behavior. Some have organizational difficulties. There are some people with ADD who know damn well what they ought to be doing. They just can't get themselves to do it. And for those people, if you can get the medication right, often that pretty well takes care of it. But there are many others who just need a lot of help in learning how to get themselves organized in order to be able to do what they need to do and to do it effectively. Some need a lot of help in learning how to manage their social relationships more effectively. Some families need some help in being able to sort out how they can get along better with one another. And there's certainly a number of people who need some help in school. Usually the hardest years for most people with ADD are junior high, high school, and the first couple of years of university, because those are the times you have the widest range of tasks to do with the least opportunity to escape from the ones you're not that good at. If you're lucky, after you get past that point, you can get a major in some field that you're really interested in. If you're really lucky, you get a job where you get paid to do something you like to do. But the fact is, not everybody gets that lucky. So let me stop at this point and ask Susan, have you got some questions there?
Sure. A couple of questions relate to, it's kind of a combination question. Are there different types of ADHD? And I'm very struck by, over doing almost 100 webinars, the questions come in from parents. They really do vary from children who are extremely hyperactive, difficult behaviorally, have a whole set of problems in that domain, to very unmotivated, spacey, kids who really have a different kind of profile. Are there different types of ADHD? That's question number one. And secondarily, what's your thinking about the idea of scanning or testing or in some way distinguishing one type of ADHD from another? Are you a believer? Is there anything in the horizon that might make that helpful? Do you foresee 20 years down the road that we'll say, oh, it's not just ADHD, it's 10 things or 5 things or whatever? Curious to know what you're thinking is
first,
on that.
The two types that have been identified for many years are the predominantly inattentive type, where you have somebody who's not showing much in the way of problems with hyperactivity or impulsivity, not much in the way of behavior problems, but a lot of trouble with being able to focus and exercise those other executive functions that we talk about so much. And then the ones who are more hyper and impulsive and where you've got more behavioral difficulties, and on top of that, usually the inattention problems as well. Now, it used to be everybody thought that ADHD went away when you got to be about 13 or 14 years old, if not before, that it was just a little kid's thing. And the reason they believed that was all they were watching was the hyperactivity, and that often does get better as you get older. By early adolescence, many of the kids who are wildly hyper as little kids are not, and sometimes they sort of slide into being the sort of unmotivated, couch potato type, or at least somebody who's kind of spacey and not, in fact, hyper at all. And so what we know about those two types are that they tend to be aspects of the similar syndrome, and that very often the hyperactivity, impulsivity just sort of tends to diminish as a person gets toward adolescence. Not always. There's some people who as adults are very hyper. They've got 2 speeds, full speed ahead or asleep and nothing much in between. But the vast majority of people who have combined type ADHD, where you've got both the inattention and hyperactivity and impulsivity symptoms, have much less difficulty with the behavioral stuff and much more difficulty with the attentional stuff as they get older and are faced with the demands of adolescence and adulthood. And there's some argument these days about sluggish cognitive tempo, people who are especially sluggish. And is that a separate thing? My read of the research on it at this point is it's not very convincing. It just seems to be just a variant of the what's called the predominantly inattentive type. But you see, it used to be, people get confused. We use the term ADD and ADHD, and up and around 1980, the term ADD was for the kind without much hyper, and the ADHD was for the kind with a hyper. And that seemed to make sense to most people, but then in 1987, when they came out with a revision of that manual, they made a mistake, I think, and decided they were going to call it all ADHD, and then you put in a comma to say which subtype. And the fact is that those subtypes don't stay constant, as I mentioned, for most others. So, I think it's my own conversations with people, I generally will use the terms ADD and ADHD interchangeably, because I don't think there's that much difference unless I have to write out a form where I've got to give a formal diagnosis. However, the other types you could talk about are people have temperament. Each child is born into the world with a certain kind of sensitivity. and various ways of reacting to things. And there are some people with ADHD who are very laid back. There's some who are very tightly wired, as is the case with people who don't have ADHD. And those underlying temperamental characteristics also make a difference. So there are different types that are not different diagnostic categories in my mind. I don't think that makes much sense, but that there are certainly people who tend to be more anxious, tend to be more excitable, tend to be more lively and animated, and others who tend to be more laid back, a little more withdrawn, a little more shy. There's a big variety among those things.
So you'd be inclined to say that there aren't a wide variety of different disorders, but rather it's a combination of temperament, interest, and personal characteristics that distinguish people.
A wide variety of people with various other characteristics.
Right.
Dimensions along which people with ADHD differ.
Okay.
But we don't need to make separate types of it.
And so, and you don't, are you, I'm guessing that you're not a believer in brain scans or other, there's a strong desire among parents to find a test.
Oh yeah, if only we had one
that'll
thing
show me what this is.
Yeah, if we only had one test that we could say definitively, yes, this is ADD or it's not. There is no such test.
Okay.
The most reliable and effective instrument we have for assessing for ADHD is a well-conducted clinical interview. And there are some people who advocate for doing brain scans. We've got various scans that we've learned a lot from in research with ADHD, but you cannot diagnose. Anybody who knows anything about imaging studies knows you cannot make a diagnosis of ADHD, yes, it's there, or no, it's not, based on any imaging study, because you're looking at a snapshot of the brain in one situation for fractions of a minute, and in some cases for just a few seconds, like a SPECT scan. And those are simply not refined to the point where you can make a diagnosis with it. There is no computer program. There's no electroencephalogram. There's no X-ray. There's no MRI. There's no SPECT scan that at this time is developed to the point where it can be used to make a diagnosis of ADHD. We simply do not have enough data. Those are very good tools for doing research, but that's a very different thing from looking at a particular person and saying, is this a person who has ADD or is it not?
Okay. There are a couple of clinicians, a teacher, others on the webinar who are wondering if you just briefly want to suggest what tools you think are most useful in an interview to diagnose ADHD. Are you a believer in the Conners? Or would you recommend any specific scales or guidelines?
For rating scales, it depends on the age group looking at. The Conners scales have been used for a long time, and they've come out in a new edition a few years ago. The BASC is often used for this, BASC, in school systems. The BRIEF, B-R-I-E-F, is often used as a measure for executive function impairments. CEFI, C-E-F-I, is used, and I've published scales for use across the age span as well. So those are all normed scales, and Barkley has come out with as well. So any of those scales can be quite useful in gathering information in a little more systematic way. Okay,
great. Just continuing down the diagnosis path before we move to treatment options. A number of people have mentioned that their children seem to have another condition, anxiety, depression, and even in some cases that they've gotten two different diagnoses from different clinicians, one saying the child had anxiety, another saying it was ADHD. How do you differentiate which one's primary, which one's secondary? Is that what should parents do in this case?
Well, it may be that both are right, or it may be that one clinician is mistaking one thing for the other. And so the most important thing is to be sure you're dealing with a clinician who's got enough experience and adequate training to be able to make a differential diagnosis. One of the problems that sometimes you run into is that because many psychologists and psychiatrists and pediatricians and the primary care providers have not had much training in ADHD in the models that we're working with these days based on more recent research, they tend to have a very narrow view of what this is and still think of it as pretty much a behavior disorder, and then, can you listen to somebody for a few minutes? Many of them don't understand how it can be that a person who's very bright can have ADHD when in fact you can. Many don't understand why it is that a kid can focus very well on video games or on watching a TV program and not be able to focus in class. And so because of that, many clinicians will make a diagnosis of the things they are more familiar with. And if a person seems a little bit anxious or a little bit bummed out, they might be more quick to move to a diagnosis of anxiety disorder or a depression disorder. Or if the person's having a little bit of trouble controlling or even quite a bit of trouble controlling emotions, they might too quickly jump to bipolar disorder as a diagnosis. They will diagnose based on what they're more familiar with if they don't have adequate understanding of the range and variety of symptoms that are characteristic of ADHD. But it's also true that many people with ADHD do have additional problems, and it's important to look for those problems. And what you decide you're going to treat first, it depends on what's making the most trouble for the person. For example, if I've got somebody who comes into my office and they're depressed, if they are having a lot of trouble eating and sleeping, and if they can't get out of bed, and if they're having thoughts that maybe they'd be better off dead, I would be likely to go first toward treatment of the depression and those depressive symptoms. And then even if I see they've got an attention deficit disorder, that would be dealt with only after we've got the primary symptoms of major depression addressed. However, if somebody else comes in and they're feeling kind of bummed out, they don't have a lot of energy, and life isn't very good, but their eating and sleeping is not all that bad, and there's certainly no indication of any suicidal thoughts or impulses, then I might be more likely to treat for the ADHD first to see if perhaps what we're dealing with is something that looks like a depression, but maybe more demoralization that comes as a result of banging your head up against a brick wall with an ADHD which is not adequately treated. So that you don't want to try throwing a whole lot of medicines at somebody all at one time, but you want to take a look at what's the whole picture and what's making the most trouble for this person at this time, what's most acute, and then prioritize the interventions according to the answer to those questions.
Okay, so let's try to treat the biggest problem first and then move to the second. But
Yeah.
It is true, is it not, that many people simultaneously have ADHD plus
It's absolutely true.
anxiety
And
plus
there are many
depression plus
people
whatever,
where
right?
there are many people where you need to be treating two or three things at one time because it's just sort of a complicated cluster of difficulties. And that's one of the reasons why a good, careful assessment is so important, because you don't want somebody who only looks at one type of problem. You want to look at the full range of things that may be getting in the way of this person. If you're dealing with somebody who's having difficulty getting along with other people and they don't seem to be able to understand very much where other people are coming from, and they come across to other people as weird and inconsiderate, you may want to think a lot about whether this is something on the autistic spectrum, even if they have a lot of symptoms of ADHD, because it's quite possible to have ADHD and Asperger's or some other autistic spectrum syndrome at the same time. And you may need to treat both of them.
Okay, that makes sense. Questions about executive function disorder. I think that there's a lot of confusion for some people as to what that is and how it's different from or the same as ADHD.
Okay, well, I can tell you that there are a lot of different terms. You see, dysexecutive syndrome, or there is no official diagnosis of executive function disorder. That's not in the book. But by executive function, what we mean is a cluster of the brain of cognitive functions that constitute the brain's management system. And the model that I work with is one that is characterized by 5 different types of things. One is getting organized and getting started on tasks. Another is being focused and be able to shift focus from one thing to another as you need to. Another is being able to regulate alertness and keep up the effort to finish things in a reasonable time. Another is being able to manage emotions, being annoyed, depressed, frustrated, worried, without having it take up too much space in your head and disrupt your functioning. And the other is utilizing working memory, where you can keep one thing in mind while doing something else. And then managing the sixth one and final one is managing impulsive and overactive behavior, being too fast or too slow. That's just a way of conceptualizing the brain's management system. And the model that I'm working with, based on the research I've been involved with, is one where you could write an equation that says ADHD equals developmental impairment of the brain's management system, or developmental impairment of executive functions. And by that I mean simply that this management system, this cluster of executive functions, which are so important, particularly as you get a little bit older and you've got to manage more things for yourself, that they don't come online in the same way that you'd expect them for somebody else of the same age and developmental level. And so in that sense, ADHD is impairment of executive function, but it's specifically a developmental impairment of it. It means it's not developing the way you'd expect it to. It's not on the usual timetable. The reason I emphasize that is it's possible to have executive function impairments for other reasons. If you have a serious motor vehicle accident, you smash your head on the windshield, you could have significant impairment of executive function depending on how much swelling there is and where in the brain it occurs. If a person has a stroke or if they have Alzheimer's dementia and there's damage to the tissue of the brain as a result of that, you may very well see impairments of executive function. Those are among some of the first symptoms of Alzheimer's. However, in those cases, usually the people have had adequate executive function and then lost it, whereas in the case of it's secondary to the tissue damage to the brain, whereas the people with ADHD just hasn't come online. But there's one more thing I'd like to say about that coming online thing. There's a very important study that was published a few years ago at the National Institute of Mental Health. They took a group of 230 kids who were carefully diagnosed with ADHD and a group of matched, typically developing kids, and did MRI scans of their brains every year and a half as they were growing up. And we know that for kids, there is all kids, there is a period that usually peaks around puberty where there's a massive proliferation of cortical cells in the brain, and then that's followed by years of pruning to get more efficient circuits. And so the question of this study was, let's look at these brains and see if the people who have ADHD have the same process of maturation of the brain that everybody else does, because usually that proliferation of cells and then pruning develops these executive functions, and around 18, 20 is about the time you begin to see it's mostly where it ought to be, sometimes a little bit later than that. And what they found was when they compared the scans, they were looking literally at 40,000 different parts of the brain with the computer technology they had at that point. And they wanted to see were there differences. And what they found was mostly no, except there are about 4 or 5 areas of the brain, not huge, but smaller areas, where the development of that maturation, that pruning process, was delayed by about 3 years on average for the group in those kids who had ADHD. And the good news was that in most of them it went on and did develop after 3 years, sometimes 4 or 5 years. These are group data, keep in mind. It's not true for every single person. But the point of the study is that most areas of the brain were developing the way they usually do, but there are these few areas that are critically important for executive function where there was a delay. And so in this case, it's a developmental delay, which a few years later was looking a lot better on quite a few of them.
Right. That's really fascinating because it would explain the 3-year lag that Dr. Barkley frequently mentions, and we frequently refer parents to.
It explains the kind of thing where I've got people showing up in my office who flunked out of college their first year because they just couldn't quite get it together to stay on top of the work and what they needed to do. And then they go back a few years later and they're honor students.
Right, exactly, yeah. There's an interesting question here from Adrienne. Thank you for asking this. She says, ask Dr. Brown, what is the most common comorbid condition that you see in your practice?
Social anxiety.
Social anxiety, yeah, wow.
The kind of nervousness that people have when they get into a situation that's not really familiar and really comfortable to them. Mm-hmm. But there are a lot of others. It depends partly on what age group you're talking about. But you see that with children and with adolescents and adults. Social anxiety is a big one. Anxiety problems of various types, big-time worriers. And you can understand how sometimes it's genetically loaded. We know this is an inherited disorder, but also inherited our tendencies toward excessive worry and excessive shyness and tendency toward being depressed and more quick to give up on things.
Right.
And these things all can feed into one another. But I also see quite a few adolescents, especially, and some adults, who smoke way too much marijuana, and they're having symptoms of ADHD, partly because they've got ADHD, but they've been made way worse by their smoking weed so much that they just don't give a damn about things they really do need to give a damn about. And so excessive drinking and excessive use of drugs, particularly one of the most common, of course, is marijuana. That's another kind of comorbid problem that I often see. And many people, if they're able to tone down their use of the drinking and the drugging to more manageable proportions, can make a big difference in terms of how they focus.
How do you treat social anxiety? And so, just people are just chiming in when you said that, saying, yes, that's what I see in my child, and social interaction, social anxiety.
That often needs some cognitive behavioral therapy or some psychotherapy to address it. And you gradually sort of stair-stepping efforts to try and help the person move toward being able to be more comfortable in these situations. Sometimes it's related to just being afraid they're going to make a fool out of themselves. That I don't want to have to get up and read in class because I'm afraid people are going to think I'm stupid. I'm afraid to raise my hand and answer a question. Or the kid will not go up to the window of McDonald's to order a hamburger for himself. It has to have somebody else to do it, even though they're old enough that most any other kid that age could do it easily. And so you have to look at those specific behavioral things and then try and gradually help them to try out doing some of this stuff that they avoid. Because the phobias are, think about a dog phobia. People who have a dog phobia do not look like they're particularly anxious unless you tell them they're going to have to go near a dog or get a dog near them. As long as they can stay away from it, they don't feel that anxious about it at all. And in the same way, social phobia is one where if a person can stay close to the interaction with just people they're already familiar with, they tend to function quite well. But it's when you have to move out and deal with new classmates, new teachers, new people in a public situation, or in a store or something like that, that's what's really scary. And so there's a progressive thing. You can't do throw them into the deep water and make them swim kind of thing with this. You need to take it a little bit at a time and gradually work with a person with some cognitive behavioral strategies usually.
Cognitive behavior strategy seems to be the most recommended for...
That's the most recommended, but there's some where the anxiety is so high we also have to use some anti-anxiety medications to deal with it. And usually that would be an SSRI rather than a short-acting medication like Xanax or something, which can get to liking too much too easily.
Aloyda, that answer was for you. That's someone who jumped in and said, he's describing my son as wants treatment for how to deal with ADHD plus social anxiety. Well, this hour is running by, so let me just jump to one of the big questions that's throughout the hundreds of questions posed here, and that is about alternatives to medicine. We have a large number of people saying that they don't want to give their child medication, or their spouse doesn't want to give their child medication, or their child doesn't do well on medication. And they're wondering about brain training, brain beat, fish oil, neurofeedback. There's every question here on every one of the alternatives. Do you have any advice in this area? As you know, people are just not comfortable with medication in many cases.
Yeah, well, the first thing to say is that there's good reason to be cautious about putting anybody on any medication, but you always have to make that decision based on weighing the risks of treating versus the risks of not treating. And there are some people whose body are quite sensitive who do not respond well to the usual stimulants. But it's also true that there are some people who don't respond well because they're started on too high a dose, or they're started on one medicine, and then either the patient and family or the physician gives up on trying anything else. And sometimes you have to move around from one option to another. But the fact is that there are some people who are afraid of medications, for example, for fear, oh, is my kid going to get addicted? I can tell you, if you've got a 5-year-old kid assessed for ADHD carefully and confirm the diagnosis, I can tell you that 5-year-old has double the risk of having a drug or alcohol problem diagnosable at some point in his or her life if they are not treated with medication. Now, that doesn't mean that they are going to get it just because they're not, but it means they're in a higher risk group. And the medications do not guarantee they're not going to get it, but they can if they're being treated during problematic periods of late childhood and early adolescence. You can reduce the risk back to what it would be for somebody else who did not have ADHD, which is still a risk factor. So there's some fears that people have that the person will lose their personality, that they'll be like zombies. If somebody's acting like a zombie, which usually means flattened affect, sort of they lose their spontaneity, they lose their sparkle, they lose their sense of humor, they don't feel much like talking to somebody, 9 times out of 10, that problem is the dose is too high or it's the wrong medication for a person. So I think the first thing to do is to try to get a realistic picture of what are the risks and the benefits of these medicines. Now, nobody can ever write a certificate for somebody saying this medicine is not going to cause you any trouble, because the fact is that there are some people whose body chemistry is particularly sensitive to one particular thing, and there are some people who drop dead after one dose of an antibiotic. It's exceedingly rare, but it does happen. There are some people who die or get serious liver damage by overdosing themselves with Tylenol. You know, the medicines that we use for ADHD we've had for a long time. There are newer delivery systems, but methylphenidate we've had since 1956. That's what's in Concerta and Ritalin and Focalin and Metadate, Concerta. And then the amphetamines we've had since 1937. That's Dexedrine, Adderall, Vyvanse. We've had these medicines a long time, and there's more research on these medicines than on any other medicine you're ever going to take. So I certainly am not saying these work for everybody. They don't. I was telling you earlier that about 8 out of 10 is the batting average, and for some that's huge, others substantial, but not huge, others not nearly as much. And I'm not saying that medicines fix everything, and I'm certainly not saying that it works for everybody, but it's certainly worth looking at seriously. Now, the next question is, all right, is there anything else that can be done? You can go online and you'll find all kinds of things advertised and really extravagant claims being made for their effectiveness. But the scientific research on it suggests that the brain's not a muscle. And these brain training programs that you can get to use with your son or daughter on the computer or for yourself, regardless of what the claims are, the reality is that they can improve your performance on the kind of tests that the computer program is teaching you to do, which is usually a very simple kind of test cognitively. But that doesn't improve a person's ability to comprehend in their reading. It doesn't improve working memory for being able to take notes in class or function better in a social situation. And the fact is that in neurofeedback, you can relax somebody with neurofeedback, and they may feel much more calm, much as they might be if we hypnotize them in a therapy session. But the generalization effects of these various brain training and relaxation strategies do not hold out to generalize to other situations in a way that really makes a difference. Studies that were completed by some of our colleagues, very good scientists in Europe recently, compared a variety of these alternative treatments. And what they found was if you ask people who are spending the money and the time to have their kid do this computer program or do these neurofeedback sessions and so forth, you get a lot of parents who are reporting, yeah, it's working very well. But if you test them against somebody who doesn't know which of these people they're checking out have had it and which have not, the results are not at all impressive. That there's a lot of enthusiasm when people have a stake in what the outcome is, and they're tending to find improvements which may be due to something quite different from what the treatment is that supposedly is supposed to be helping.
How about supplements? Yeah, fish oils,
dietary supplements Again, there's some people who go to homeopathic physicians and they get a list of a hair sample or something and a list of you're a little high on this and a little low on that. There's not much evidence at all that this stuff works. Fish oil, yes, it does provide some help for some things, but making a significant improvement on symptoms of ADHD isn't one of them. There's controversies in the literature, and because these things take on almost religious dimensions as people argue for one side or another. But if you look at the hard science of it, we're dealing fundamentally with chemical problems in the brain. And the most effective treatment for most people is if we can change the chemistry. We cannot always do that. If you've got two parents and one of them wants to try medicine and the other one doesn't, it might be a good idea for both of them to get some objective information about what the risks and benefits are. And when I talk with families, I always try not to oversell it. I have to say, I can't promise you medicine is going to help you. I can tell you your odds are 8 for 10. And I think we need to be honest about that and then not overdo it. Yes, there are side effects. Sometimes it can make you have some headaches when you get started or some stomach aches. Sometimes it can make your appetite go down so you're not so interested in eating lunch. If you take it too close to bedtime, it can make it a little harder to get to sleep at night, but those are all things we can usually adjust for. So it's not as though medicine always works, but there are many people who back off of even trying it or give up too quickly in trying it because they haven't had enough help to be able to do it sensibly.
Yeah, I think that's a big issue for people, finding a doctor who will help them work through the options and the doses and the side effects, which it sounds as if it takes a great deal, not a significant effort to get, if you do go the medication route, to get that working correctly.
Yeah, and also
not everybody
needs a clinician who's willing to ask the questions and listen to the answers.
Right.
Because you need help from the patient. Even if it's a child, they can often tell you a lot about what time of day does it happen. For example, I've had some people come in and say, I don't like that medicine because it makes me feel crabby. And then I ask them, when does it make you feel crabby? Does it happen during the time it's supposed to be working, or does it happen more when it's wearing off? And if they're telling me that it's almost all the time, it's from the time they've ingested the medication until the end of the day, I'd say, okay, we either got the dose too high or this is the wrong medicine for the person. But if they're not having it during most of the day and they get it late in the day when you'd expect the medicine to be wearing off, that is a completely different problem. That is not because the medicine is causing it. It's because they're getting a rebound when the medicine's wearing off and they're crashing, which is something that can easily be dealt with by giving a small dose of the short-acting version of whatever that medicine is, so you can taper down that curve as it's coming off a little more gently so the person isn't crashing.
We are so sorry we're out of time. This is a great discussion, and there's so many terrific questions here that I would love to be able to answer. One person who's just been really anxious to get an answer for several webinars is about someone asking about 2E kids who are highly gifted as well as ADHD. We're just not going to have time to discuss that today, but I want to refer you to Dr. Brown's book, Stuck. Is it
Smart but Stuck?
Smart but Stuck. Wonderful book about kids who, for the most part, are very bright and also have attention deficit disorder.
Yeah, and if I could add in, on my website, there also are 2 papers where we've done research studies on high IQ folks with ADHD.
Okay, great. So thank you so much, Dr. Brown. We appreciate it. Thank you, everyone. Thank you so much, Dr. Brown, as always.
Thanks, Susan. Bye-bye.
Bye.
For more Attitude Podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.